Very good morning to all of you. Today we will discuss the very important topic, the illusions of the physiotherapist or manual therapist. Illusions mean what we are thinking in our treatment, but actually it doesn't happen. So we start with our topic, illusion of the physiotherapist or manual therapist. First, we came to palpation of C7 and L5 vertebrae. When we are palpating the C5, C7 or L5 vertebra, we are thinking that we are on right place with the spinous process, what we are palpating. But it doesn't happen. In this study, two manual therapists examined 49 patients, 29 women, age between 26 and 79 years, 18 were cervical and 31 lumbar patients. An invisible marking pen and ultraviolet light were used, and the findings were compared. X-ray were taken as an objective measure of the correct spinal level. Percentage agreement and kappa statics were used to evaluate reliability and validity. The best inter-therapist agreement was found for the skin marks. Percentage agreement within 10 mm and 20 mm was 67% and 85% respectively. The inter-tester reliability for identifying a radiological nominated spinous process by palpation was found to be poor for C7 and moderate for L5 with kappa of 0.8 and 0.48 respectively. When we are manually palpating the C7 spinous process, it was very simple and very easy to palpate, and it is very prominent in the human body. After that, it was found very poor in C7. In that, you can realize where we are palpating, and we are palpating right spinous process or no. Next, we come to the palpation of iliac crest and PSIS. Iliac crest and PSIS is also very easy to palpate. In this study, the conclusion of the study was that 49% of the cases there was inaccurate identification of spinal level by the palpation of iliac crest in cephalad direction. More so in elderly patient, the patient with higher BMI. So in this case, clinical should be in doubtful of the palpated landmark to be corresponding to the higher level. PSIS line ranges from L4, L5 interspace to S2 spinous process, and therefore cannot be reliable guide for identification of spinal level. Now you can realize 132 patients were taken in this study, and only 49% was inaccurate. That means only 51 cases are accurate, rest 49 was wrong. And iliac crest is so easy to identify. Now come to the palpation of lumbopelvic landmark. In this study, this is a systemic review, the validity of lumbopelvic landmark palpation by manual practitioner, and the conclusion was the use of lumbopelvic landmark palpation does not reach clinically acceptable level of validity. Now come to the neck joint mobilization. Now the manual therapist very popularly and very successfully mobilize the neck joint, that is facet joint or zygoepiphyseal joint. So neck joint mobilization doesn't mobilize neck joint. What it means? Whenever we are mobilizing the neck and we are thinking we are mobilizing the neck joint, it is a just illusion. We are not able to mobilize facet joint by our hands. So even the soft tissue didn't deform that much, about 10 to 12 mm only. This is the study in 2001, McGraw et al. Clinical biomechanics. But a study from 2001 asked experienced therapists to do the same technique on patient in an open MRI machine. When experienced therapist mobilized the neck joint in an open MRI, then it shows the movement of less than 0.5 mm of the facet joints. Grade 1 and grade 4 posterior anterior mobilization applied from C2 to C6. No intervertebral movement was observed, only soft tissue deformation was observed in open MRI. Now come to the SI joint mobilization and manipulation. We are mobilized SI joint very frequently, but SI joint mobilization is not possible by our hands. Manipulation we can manipulate, but what are the findings? These are the manual counter-nutrition techniques of SI joint. There is strong evidence that intra-articular displacement within the SI joint do not occur, and pelvic manipulation doesn't alter the position of the pelvic joint. LUMBAR et al. In 1992. Now come to the second study, unilateral posterior pelvic mobilization and unilateral anterior pelvic mobilization of a healthy adult man resulted in no significant changes in the sagittal, frontal and transverse position of the pelvis when measured by non-invasive method. Richard et al. In 2015. So lumbar spine mobilization through spinous process. When we are mobilizing the lumbar spine through the spinous process, what happened? The result of this study confirmed that mobilization treatment has an immediate effect in relieving low back pain. However, the specific technique used seems unimportant. The joint is not mobilized at all, but it relieves the back pain. That is the conclusion of this study. So lumbar spine mobilization through the transverse process. When we are mobilizing the lumbar spine through the transverse process, manual mobilization of the lumbar spine through transverse process is just a deep ischemic pressure rather than gliding the joint. When we are thinking we are gliding the joint, it doesn't happen. Only just a ischemic pressure is there, and that's why the pain is relieved and there is no gliding, no mobilization of the joint. Testing segmental mobility by palpation. Some of the therapists, senior therapists, are palpating and assessing the mobility of the joint. So what happens? Segmental mobility testing by palpation. There are so many techniques and methods. Manual palpation of segmental mobility in the lumbar spine probably is the best way to reach the useless diagnosis. We cannot palpate the hypermobility of the or hypomobility by the palpation. A new paradigm in the manual therapy Abandoning segmental motion palpation, article July 2016, there will always be evidence deniers in every profession, but the majority of the manual physiotherapists appear to be refusing to accept evidence disapproving manual motion testing. Although it may be difficult, it is essential for the healthcare provider to embrace emerging evidence and move forward, which in turn will inevitably benefit the patient aimed to serve. Now come to the spinal stiffness and hypomobility by the manual assessment. Result indicated that manual assessment uncorrelated to criteria measure of stiffness. Spermian RHO is equal to 0.06, P is equal to 0.67. Similarly, sensitivity and specificity estimate of judgment of hypomobility were low, 0.20 to 0.045, and likelihood ratio were generally not statistically significant. Criteria validity of manual assessment of spinal stiffness by Shane L. Copenhaver, PhD et al. 2013. Now come to the manipulation of specific vertebra. C3 to C7, L1 to L5. Some of the manual therapists, researchers, they are claimed that we are manipulating the specific level of vertebra. That is, we are manipulating C1, C2, C3 to C4 or C4, C5, C6, C7 or L1, L2, L2, L3, L4, L5. For the specific vertebra, we cannot prove that that specific level we are manipulating. When a popping sound is coming, it's coming from anywhere. We cannot explain or we cannot justify that it is coming from just this particular level. Now come to our modalities. Ultrasound, very popular. Ultrasound therapy for musculoskeletal disorder. This is a systemic review. In this study, the conclusion was, as yet, there seemed to be little evidence to support the use of ultrasound therapy in the treatment of musculoskeletal disorders. The large majority of 13 randomized placebo-controlled trials with adequate method did not support the existence of clinically important or statistically significant difference in favor of ultrasound therapy. Now comes the pulse shortwave therapy. In this article or in this study, the conclusion was the addition of pulse shortwave or manual therapy to advice and exercise did not provide any additional benefit in the physical therapy treatment of neck disorders, only in neck disorders. In another study, pulse electromagnetic energy therapy, the conclusion was the systemic review provided further evidence that PEMF has little value in the management of knee osteoarthritis. There appear to be clear evidence for the recommendation that PEMF does not significantly reduce the pain of knee osteoarthritis. Now come to the TENS. In this study, assessment efficacy of transcutaneous electric stimulation in the treatment of pain in the neurological disorder, only in neurologic disorders. The transcutaneous nerve stimulation is not recommended for the treatment of chronic low back pain and should be considered in the treatment of painful diabetic neuropathy level B. Further research into the mechanism of action of TENS is needed as well as more rigorous study for determination of efficacy. This is another study of TENS. The conclusion was there was no functional benefit of TENS in the treatment of patient with chronic low back pain. Now come to the traction. In this study, the efficacy of traction for low back and neck pain, a systemic blinded review of randomized clinical trial method. In this conclusion and discussion, the available reports of the study on the efficacy of traction for the back and neck pain do not allow clear conclusion due to methodological flaws in their design and conduct. So there is no clear conclusion. So we need more specific study for the efficacy of traction in neck pain and back pain. Next is, by the age of 30, the nucleus is indistinguishable. So traction is beneficial only in the case of nuclear protrusion. Or any other case, traction is not beneficial. Come to the manual therapy. In manual therapy, in this study, effectiveness of manual therapy or pulse shortwave therapy, in addition to advice and exercise for neck disorders. Conclusion was the addition of pulse shortwave and manual therapy to advice and exercise did not provide any additional benefit in the physical therapy treatment of neck disorders. This is another study of manual therapy in shoulder. So, manual therapy was not shown to be more effective than other conservative intervention for AC joint. However, massage and mobilization with movement may be useful in comparison to no treatment for short-term outcomes for the shoulder dysfunction. Now come to our most favorite, lumbar support. Lumbar support for prevention and treatment of low back pain. Nowadays, it's a session about prescribing the lumbar support for any back pain patient. And what this study says that the systemic review of therapeutic trial shows that there is a limited evidence that lumbar support is more effective than no treatment, while it is still unclear if lumbar supports are more effective than other intervention for treatment of low back. Next is cervical collar. The effect of cervical soft collar on persistent neck pain in patient with whiplash injury. What is the conclusion of this study? The most patients with whiplash injury have persistent pain for at least 6 weeks. Soft cervical collar do not influence the duration or degree of persistent pain. That means whether you apply soft collar or not, it doesn't affect the pain or duration. Now come to the MRI. In this study, these are the abnormalities are found in the asymptomatic people in which there is no symptom, but 1,1211 disc bulging, 87% found in this patient. Partial rotator cuff tear, 22%, bursa thickening, 78%, overall abnormalities, 96% in 51 patient age 40 to 70 years. Systemic review 2140 asymptomatic hips, cam deformity 37%, pincer deformity 67%, labral injury 68%. Disc degeneration systemic review 3110 patient, 37% 20 years to 96% 80 years. Systemic review 5397 knees, OA 19 to 43%, 4 to 14% cartilage defect, 11 meniscal tear 19%, in foot 48 men, Morton neuroma 54%, 320 MRI, median age 51, ATFL pathology 37. These are the findings of asymptomatic persons. And in this journal, the conclusion about MRI was that on MRI examination of lumbar spine, many people without back pain have disc bulge or protrusion, but no extrusion, given the high prevalence of this finding and the back pain. The discovery by MRI of bulge or protrusion in people with low back pain may frequently be coincidental. And this one another study, in this one same patient is MRI is taken on 10 different MRI center, and all MRI center give different report of the same patient. So MRI report also depend upon how and who is giving the report, what the person is perceive or predict about their knowledge and about the report. So it is not we treating the MRI, CT scan or X-ray. We are here to treat the patient, not the scans. So by the evidence-based practice, this is the guidelines for back pain and radiculopathy. Not affected, do not do this treatment, that is tense, traction, support, electrotherapy, acupuncture. Evidence uncertain, consider after other treatment, massage, manual therapy, yoga, psychological treatment combined with physiological. Evidence effective, do this treatment, lifestyle advice, pharmacological treatment, physical therapy, exercise program, nerve root injection after 6 weeks if severe. This is the evidence-based program. Now come to the passive stretching. So whenever you are treating the patient, remember this, my humble request. Passive stretching is not for patient. Stretching, passive stretching is for normal person or sports person. When you are giving the stretching, you damage or you worsen the position of the patient by giving the micro trauma to the muscle or other soft tissue structure. So besides stretching, use MFR or any other suitable technique. Now come to the stretch weakness. So what is stretch weakness? When the muscles are in a lengthened position for a longest period, they become lengthened and they become weak. As in IT professions, students, white collar job, the forward posture is also there. So in this stretch weakness, never give hot therapy or heat therapy. So what is the reason behind this? Whenever you are giving heat to already lengthen muscles, then after applying heat, the muscle is relaxed and it more lengthen. It's already in lengthened position, so it more lengthen. And there is no relief to the patient, only symptomatic relief that after the treatment, after the applying of heat, patient is feeling good, but therapeutically, it doesn't give any therapeutical benefit. So, what kind of treatment you give in this stretch weakness? You give strengthening exercise. So remind yourself that you don't have to do whatever everyone else is doing. Be special, be different, just be yourself. They laugh at me because I am different. I laugh at them because they all are same. So no matter how long you have traveled in a wrong direction, you can always turn around. Have a successful day. Thank you. Thank you for your patience. Good day.